Good afternoon, everybody. Now, my topic on today's session is status and application of cytology in modern day diagnosis. So, by the term cytology, we mean the study of the function and structure of cells. But basically, our understanding about cytology in day-to-day practice is the study of cytomorphology. The lesional cells are collected in the form of aspirate, scrape smear, or the centrifuge deposit of the body fluids and are sprayed on the glass slides, and then a set of slides are air dried and the rest of the slides are alcohol fixed. The air dried slides are stained by May granular ginseng MGG, a kind of Romanowski stain, and the alcohol fixed slides are stained by Papanicolaou, PAP, or hematoxylin and eosin, HNE. And then the stained slides are undergone microscopic examination by the pathologists. So, according to the types of procurement of the cytology material, this can be exfoliative cytology, fine needle aspiration cytology, imprint cytology, and squash cytology. So, cervical cytology, body fluid cytology, brush cytology in the form of bronchial brush, and lavage fluid like bronchoalveolar lavage are examples of exfoliative cytology. And we know about the fine needle aspiration, where the needle material is collected by fine needle and syringe, and that material is sprayed on the slide and stained subsequently, and there go slide microscopic examination. Imprint cytology is usually done while doing the true cut biopsy or core needle biopsy or bone marrow biopsy. So the core of tissue is placed on the glass slide and imprint is taken, and that is stained subsequently. And squash cytology in connection with the brain tumor. Now let us have a look on different smears, cytology smears. This is a cervical PAP, cervical smear cytology stained by PAP Papanicolaou. We can see the superficial and intermediate squamous cells. These microphotographs are taken from the FNSE material from different lesions. In the upper left, we can see a smear from adenocarcinoma of lung, where you can see the well-formed papillae with the pleomorphic appearance of the cells, and also intracytoplasmic mucin blobs are there. And this lower left one is taken from a sarcoma, where we can see the pleomorphic hyperchromatic cells arranged in dispersed fashion. The upper right is taken from a benign inflammatory lesion of lung, where benign epithelial cell clusters on a background inflammatory cells are there. And this one taken from a tuberculous lesion, where we can see the granulomas. So, up to this microscopic examination of this cytology material is providing us about the nature of the lesion, whether this is neoplastic or non-neoplastic. When neoplastic, it is benign or malignant or epithelial or mesenchymal in nature. When this is non-neoplastic, whether this is a non-specific inflammation or having any evidence of any specific infection like tuberculosis or fungal infection, etc. So up to this, the cytology is playing a vital role as a screening tool in diagnostic field. But this was the starting of the journey of cytology, from where as time passes and technology takes over with extensive research work and consensus opinion, cytology has reached to such a dimension where it is ready to accept all the challenges of modern day diagnosis. Now we have seen advancement in almost all steps of cytology, starting from the sample collection, where we have seen the aid of radiology or endoscopy, and we can access to intra-abdominal or intrathoracic lesion by the guidance of ultrasound or CT. Similarly, endoscopic, there are some lesions in endobronchial or endosophageal or pancreaticobiliary tree. These lesions are very difficult to get access. So endoscopic ultrasound guidance can help a lot to get the material from these difficult lesions. TBNA, transbronchial needle aspiration, is also there. When this is combined with endobronchial EBUS, ultrasound guidance and transbronchial approach, we can get access to paratracheal and even mediastinal lymph nodes also to get the material, to aspirate the material from these lesions. So we have seen the support of modern advancement in collection of material in cytology. Now let us have a look of our CT guided FNSs, where we can see the small lesions, interthoracic lesions, are approached there by our CT guidance. The materials are aspirated from these lesions. One is very small lesion, this one also. This is a vertebral lesion. You can see the destruction of the vertebra. This came out to be metastatic adenocarcinoma. This one is again a destructive vertebral lesion, and the needle here you can see. So this came out to be tuberculosis. This one lesion from kidney as well. So similarly, advancement is also seen in sample preparation. Initially, we are familiar with the conventional type of smears, where the material is collected and sprayed on glass slide manually by a spreader or another slide. And still now, these conventional smears serves a lot in standard cytology practice. But this has got also some difficulty and problem, like cell overlap, obscuring factor like inflammation or hemorrhage are there, which is particularly problematic when we examine the cytology, gynecological cytology smears like cervical path. And then the concept of cell suspension emerged, and we have got the liquid based cytology, where the cell suspension are used to produce a single layer of cells on the glass slide. There are some advantages, like it reduces the unsatisfactory for evaluation rate. There is definitely improved fixation, and the sample is devoid of operator dependent variation. There is better appreciation of cytomorphology, immunochemistry, and additional testing for HPV can be done, particularly which is nowadays very important. As we know, as per latest Bethesda guideline, the HPV testing is essential part of cervical smear examination. If we get in conventional way, the material is collected by spatula, only small portion of that is kept on the slide and smear is prepared and examined. The rest part is discarded. But if we made a cell suspension by that material and prepare liquid based cytology smears, then additional material can be submitted for HPV testing. So what is the picture of LBC gynecological? You can see that there are so many approved systems like SurePath, InPrep, SpinThin, etc. I am not going to the detailed technical aspect of these techniques or systems. And in case of non-gynecological liquid-based cytology also, we see the use of automatic monolayer devices is becoming much more popular in FNSC. SurePath and ThinPrep processors have been approved for FNA material, and cytocentrifuge like cytospin 2, cytospin 3 used in fluid cytology overcomes the distortion of cells in monolayer preparation. Obviously, there are some disadvantages of LBC like degeneration or shrinkage of the cells, which may have a negative impact on intactness of DNA quality. There may be unusual dispersion of the cells and clustering of the cells. And another important thing, the physical quality like charge of the slide used for LBC, liquid-based cytology, fully frosted or non-frosted nature of the cells may have some effect on DNA quality, and this is now a questionable issue. Now coming to the cell block preparation, this is another way of presenting the cytology material. When the material is collected and satisfactory number of smears are done, the rest of the material can be submitted for cell block preparation. Sometimes extra pass or additional dedicated pass may be done to collect more material, and that material is submitted for cell block preparation, fixed in formalin, centrifuged, and cell pellet is formed. There are so many methods of forming cell pellets like plasma thrombin, histogel, tissue coagulum, collodion, etc. So after getting that cell pellet done, then that cell pellet can be submitted for routine processing as we do in case of small biopsy sample, and subsequently formalin fixed paraffin embedded cell blocks can be prepared. So there are so many advantages of this. These cell block sections are source of multiple additional sections, and this can be applicable for evaluation of more cells, better demonstration of more architecture, and ancillary studies like spatial stain, IAC, ultrastructure analysis, and molecular can be done on this cell block platform. Obviously, there are some disadvantages also. Reduced morphological quality of the cells is one important disadvantage of cell block preparation. Now let us have a look of our cell block preparation. The upper left one is a cell block from adenocarcinoma of lung. We can see the papilla, the acinar pattern, so the enhanced architecture, the malignant nature of cells and mucoid background. So this is taken from adenocarcinoma of lung, this cell block, and the right one is showing malignant cells, epithelial in nature, but no definite pattern can be appreciated. Only we can see that solid sheets of cells. So this is a non-small cell, poorly differentiated non-small cell carcinoma of lung. Now coming to the ancillary testing. So cytology specimen is now offering a reliable platform for ancillary testing also. We know there are so many spatial stains like PAS, other fungal stains, mucin stains, so all these can be successfully done on cell block platform. Also, some of the stains can be done on direct cytology smears also. Now coming to the immunochemistry. So all we know the basic principle of immunochemistry, where the commercially available monoclonal antibodies are applied to target the molecules expressed by different lineage of cells, like cytokeratin for epithelial cells, chromogranin for neuroendocrine cells, LCA from lymphoma cells, TTF1 from adenocarcinoma, lung and carcinoma of thyroid cells, napsin A from adenocarcinoma of lung, P40, P63 for squamous cell carcinoma. So this immunochemistry was tried initially on the smears, cytology smears, but the technical difficulty and excessive background staining interfering, the result became disappointing. However, liquid-based cytology have some advantageous position regarding the avoidance of background staining. Cell block in this regard is now much more useful, and formalin fixed paraffin embedded cell blocks like FFPE cell blocks are now validated platform for immunohistochemistry or immunochemistry. And we see these IHC tests to detect the different lineage of cells can be easily done on cell blocks. And also, as we know nowadays, the different abnormal products of abnormal genes like EGFR mutation is now being done on IHC base. And also the ALK, if we consider the adenocarcinoma of lung, then we can see that ALK protein or product of Ross gene rearrangement, all these proteins or molecules can be successfully detected by IHC. Thus, IHC has become the first line of test for detection of these molecules because of its cost effectiveness, high sensitivity and high specificity. So, cell block being obtained by a minimal invasive technique and providing a validated platform for this ISC now has become very much useful for detection of these molecules also. Now coming to the molecular study. So we know that PCR, FISH and gene sequencing are the molecular techniques to detect the gene mutation or gene rearrangement products, and thus helping it in the diagnosis and also application of specific targeted therapy. So if we discuss it in the context of adenocarcinoma of lung, see if there is mutation found in EGFR receptor mutation, so then targeted therapy should be a first generation tyrosine kinase inhibitor, TKI. Similarly, if there is detection of ALK or ROS1, crizotinib is the targeted therapeutic strategy. So that's how it is helping in the diagnosis as well as personalized medicine. These molecular techniques are also helping in assessment of prognostic factors. So cell block, as I have already told, is also providing a validated platform. That formalin fixed paraffin embedded cell blocks are providing a validated platform for these molecular techniques. Although it has got also some disadvantages due to the deterioration of DNA quality because of formalin cross-link formation and DNA fragmentation. Conventional or direct cytology smears in this sense have some advantages because of intactness of cell nuclei and DNA quality, and thus direct smears may ultimately prove to be the cytology platform best suited for molecular techniques. Now coming to the reporting, standardization of the reporting. So we have already seen that cytology is now going hand in hand with the ancillary techniques like immunohistochemistry and also molecular biology. But still now, the backbone of cytology reporting in day-to-day practice is the study of cytomorphology. And here lies the chances of biasness. Biasness in the form of inter-observer biasness, biasness in the form of inter-institutional biasness, and sometimes the use of some terminologies like atypical, suspicious, intermediate fails to convey the right diagnostic and therapeutic path to the clinician. Highly specialized multiple terminologies are sometimes used to describe the same disease entity. This also creates a confusion. So all these together obviates the need of development of more standardized terminologies and training or education of the clinicians to get familiar into these terminologies. So multidisciplinary meetings with the participation of specialists of different specialties from diagnostic side and clinical sides are now being done to form consensus opinion, to standardize for the standardization of reporting system, which have got some acceptance and adequacy criteria. Consensus opinion are formed to form the evidence-based development of specific terminology to describe the specific. And this has got a reflection of current understanding of exact pathology. Communicates clearly the cytological findings to the outcome probability, thus helping the clinicians to choose optimal management options. The Bethesda system for cervical cytology 1988 laid the way of standardized reporting, and it has been successful to become a model. It communicates clearly the relevant information from the lab to the healthcare providers, which has got an uniform, reasonably reproducible across different pathologies, and reflects most of the understanding of cervical neoplasm. Specimen adequacy was addressed, and it correlates morphology with the biology of the disease. Recognize the reality of poor reproducibility of the term atypia. The use of standardization in this quality of non-gynecological reporting was encouraged by Clothers et al. In 2009. The Bethesda Thyroid Atlas project and the framework for the Bethesda system for reporting of thyroid cytology evolved to address the terminology and other issues related to fine needle aspiration thyroid. The Paris System Working Group provides a standardized platform for reporting the cytological interpretation of urine samples. The Milan system for reporting salivary gland cytopathology helps to produce a more uniform diagnostic structure, like improved communication between treating clinician and pathologist, and thereby improving the patient care. For breast, apart from other grading system, Robinson grading system, based on the evaluation of cytology grade using fine needle aspiration, determines the aggressiveness of the breast carcinoma, which is an useful parameter when selecting neoadjuvant therapy for the breast carcinoma. So we have seen so many systems, so many consensus opinion are trying to standardize the reporting system in cytology. And let us have a look in the Bethesda system for reporting of thyroid cytology, recommended diagnostic categories. See, the categories 1, 2, 3, 4, 5 and 6 are there. Category 1 is non-diagnostic or unsatisfactory. There, the finding is also given. Like when we get only cyst fluid or virtually acellular smear or other obscuring factors, then our report should be categorized as non-diagnostic or unsatisfactory. That is category 1. Similarly, other findings are also given here. According to that finding, the other subsequent grading category will be reflected in our cytology report. Now, if we have a look on this implied risk of malignancy and recommended clinical management, in the left side we see that when our report is of non-diagnostic or unsatisfactory category, the management will be repeat FNSC with ultrasound guidance. When it belongs to benign category, then our management will be clinical follow-up. When the report will be atypia of undetermined significance or follicular lesion of undetermined significance, then repeat FNSC will be the recommended management. So that's how we can see it is the standardization of reporting which leads to standardization of management and thereby improving the patient care. So these are different systems. You can have a quick look on this. This is the Paris system of reporting urinary cytology. Here also we can see different categories like non-diagnostic or unsatisfactory, negative for high-grade urothelial carcinoma, atypical urothelial cell AUC, suspicious of high-grade urothelial carcinoma, high-grade urothelial carcinoma, low-grade urothelial neoplasm, others. So the findings are also given. As per this finding, we can categorize our report according to this recommendation. This is the Robinson's grading system. I'm not going to the detail of that. The scores are given 1, 2, 3 and different cell dissociation, cell size, cell uniformity, nucleoli. All these headings are there according to the severity. The scoring increases and that's how overall scoring is done. This is the Milan system of reporting for salivary gland cytology. Here also the diagnostic categories like non-diagnostic, non-neoplastic, atypia of undetermined significance, neoplastic, suspicious of malignant are different categories. Okay. So we have seen the effort to standardize the cytology report in our modern day cytology practice. Now comes the quality control and quality assurance issue. So in modern days, all the quality labs are participating in quality control and quality assurance program in this era of heightened accountability. So they try to increase the sensitivity of the methods by reducing and try to reduce the false negative results by optimization and standardization of material and methods. So there are some regulations also like Clinical Lab Improvement Act, CLIA guidelines 1988. As per their guidelines, the recommended thing is random rescreening of 10% of the negative gynae specimens done. There is simple and unified approach widely diverse for the widely diverse non-gynecological specimens. Goals and objectives are set for all steps, and standards are set for the lab personnel, the equipments, the physical lab facilities like space, humidity, ventilation, etc., and also safety requirements. Regular monitoring of internal quality and participation in diverse external audit and documentation of corrective measures are taken as per NABL recommendations. And last but not the least is the role of the pathologist. The pathologist is not only supposed to prepare a report with the skill and competency, but also the pathologists are the persons who can provide guidance for the relevant ancillary testing, and that's how bridging the diagnostic side with the clinical side. And they are to make clinicians aware of the limitation of the pathologist in case of inadequate or irrelevant samples. And they are the persons to sensitize the clinician to strengthen the communication with the pathologist. So that's how, along with this advancement in science, technology, and their support in cytology, the feeling and concern of the lab personnel, clinicians, and finally the pathologists can make the cytology as one of the strong pillars in modern day diagnosis.